aspects of COVID-19. First, I'd like to make a few housekeeping comments. Ask each speaker to limit their comments to 25 minutes so that we have some time for questions after each lecture. The questions will be triaged by Victoria Stabile of Duke University. We have over 1,000 persons registered, so unfortunately, we may not be able to answer all questions. We hope to have some time at the end of the webinar for a general panel discussion and question and answer period. I'd like to call your attention to the slide announcing the 11th World Congress for Neurorehabilitation. This is a joint conference between the WFNR and the Physical and Rehabilitation Medicine Group from France. It was originally scheduled to be an in-person Congress, but it's now been converted to a digital Congress because of the pandemic. The dates, as you can see on the slide, are October 7 to 11 of this year. Registration is now available on the WFNR website. Now, many of you are probably interested in continuing medical education credit for today's webinar. Instructions for claiming CME credit will be presented at the end of the webinar today. Finally, I'd like to thank Duke University and Dr. Wayne Feng for their technical support in arranging this webinar. There'll also be a survey during the webinar to tell us a little bit about who you are, where you're from, what your discipline is, and that's quite interesting. Again, we have a very large audience and we appreciate you for joining us today. All right, with that, I'd like to introduce my co-chair, Professor Humberg, who will make a few additional comments prior to our first lecture.
Okay, well, hello everybody around the world. I think it's very important that also the world of neurorehabilitation takes into account all the problems we have with the COVID-19 pandemic around the world, which certainly exerts a lot of problems into the field of neurorehabilitation in many aspects. I will address that in detail. And also during the digital October World Congress, we will certainly address this in even more detail with a lot of speakers. Okay, that's all I want to say.
Okay. Well, I think at this point, I'll go ahead and introduce our first speaker, Dr. Wayne Feng. Dr. Feng is a professor in the Department of Neurology at Duke University Center in North Carolina, USA. And he's chief of the Vascular Neurology Division. He's medical director of the Duke Comprehensive Stroke Center. Prior to that, he was on the faculty of the Medical College of South Carolina. His areas of expertise include vascular neurology, biostatistics and epidemiology, neuroimaging, and brain stimulation. He's a fellow of several professional societies. He is a member of the World Federation for Neurorehabilitation Presidium, and he's the vice chair of the Neural Repair and Neurorehabilitation section of the American Academy of Neurology. He's a member of the editorial board of several journals, and he's author of multiple peer-reviewed publications. He's a well-funded researcher. His topic today is the impact of the SARS CoV-2 on stroke and stroke care. Professor Feng.
Okay, thanks. Thanks, David. Can you guys hear me okay, the panel?
Yes.
Yep.
Okay, all right. Well, well, welcome to the in a symposium by the World Federation of Neurorehabilitation. As a two-chair point out, and as we enter the pandemic, and the first phase we really focus on acute treatment, but now we realize there is a series of neurological complication from the COVID-19. So this symposium really focuses on the neurological complication of COVID-19. My topic will basically talk about the impact of a SARS CoV-2 to stroke and stroke care, because stroke is one of the common complications from COVID-19. This is our second symposiums. We had one just about and less than 2 months ago. At that time, we only have 500,000 of a case. I just pulled the data early this morning. Now we have almost 1.4 million cases worldwide. So it's a significant increase in the last few weeks. So COVID-19 is actually called, the virus actually called a severe acute respiratory syndrome coronavirus 2. It mainly spread between people during close contact and frequently through the small droplets and produced by cough, sneezing, or simply just talk to each other if we're getting really close. The incubation time is about 2 days to 14 days. But the lung is the most organ effect, but now we understand it. It's not just invade the lung, it's affect multi-organs and in the bodies. And I'm not sure why my slides are not advancing.
Right, that was perfect. Now you're on the coronavirus disease
Yeah,
2019.
okay, good now. So this slide, as I point out, it's basically a multi-organ in a disease. This slides kind of show you, it can affect the lungs, affect the broader stream, goes through the nerve, or affect the bulbar, and it really can affect literally all the organ in the bodies. And another slides kind of show you how predominantly affect the neurological systems. And there are a variety of diseases that has been discovered and ranging from stroke, encephalopathy, encephalitis, and some of the neuropathy, so which we'll discuss a little bit later, but majority of it and the talks really focus on cerebral vascular disease. The first report about the neurological complications is really come from the Wuhan when the disease first started. On this slides we can tell in about 214 cases, and a majority of them exhibit some sort of neurological symptom, and ranging from dizziness, headache, impaired consciousness. Stroke is a small proportion of the patient, about 3%. Okay, and also interesting also at that time they actually noticed some of the patients actually lost the taste, lost the smell, actually lost the vision, and then realized it's getting quite a common, and a lot of patients actually lost it and the taste, the smell, and as well vision. This was presented by the one hospital in New York, and it got a lot of media attention. And basically, a group of patients, and literally about 5 patients, and then they're all very young, ranging from 33 to 49. They don't really have much vascular risk. And suddenly they all present with large vessels and a stroke, and some they get treated, some didn't get treated, and then the cause of stroke was not very clear. And this almost really caused a lot of panic in the public. And shortly a few weeks later, and there's a report that comes from NYU, basically look at the whole entire database, really assess what are really the real impact of the SARS CoV-2 and to the stroke. We feel a little better after this report come out, and basically, they find that there's a very low rate of imaging confirmed stroke in hospital in a patient with COVID-19. As we can tell, the daily and COVID-19 in cases range by 1,200 every day, but look at number of stroke, really just by 10. And this is the entire healthcare system at New York, okay? But interestingly, they also find that most of stroke, the mechanisms are cryptogenic, means we really don't know, and the suspect are probably related to hypercoagulability. And then they also noticed the mortality significant increase. I have one more slide to show you, and just look at this cohort, the COVID-19 positive and the COVID-19 negative, as this is kind of historic control and group, they all have a stroke. So, and one striking and feature is very high level of a D dimer, suggesting there are some and a hypercoagulability and occurred to those patients. And a similar CRP shows significant inflammations. And there's a tremendous difference between the COVID-19 positive case and COVID-19 negative case. Then let's look at the etiology of stroke. One of the biggest striking is really the significant high number of patients presents with cryptogenic. Means we really don't know exactly etiology. If you look at the rest of etiology is pretty similar across the two groups. Among those cryptogenic, and those are all we know, those are embolus, but we just don't know where exactly come from. Okay, so clear suggests there are some coagulability and associated with those stroke patients. As we have more publications, and also we we also have autopsy on some of the cases. This paper actually just came out on Brain just last week. It's a retrospective and a registry in Spain. Basically, they recorded almost 1,700 in a stroke patient. The good part is only 23 patients had a COVID-19 and had a stroke at the same time. And 17 cases was ischemic stroke, and 5 cases are in a hemorrhagic stroke, and there's one just suppressed, and the posterior reversible encephalopathy syndrome. And then they're able to collect some historic examples and able to examine in 6 cases. 2, they did a brain biopsy, including one just shown on the left side slide. So you can show, this is a small vessel, and you can see really destruction of the endothelial cell. And you barely just don't see any endothelial cell over here. Versus this square box, you can see, you still see this an intact vessel and with line up with endothelial cell. The both brain biopsies show they are thrombotic and microangiopathy and also endothelial injury. But they didn't find a clear evidence of vasculitis or necrotizing encephalitis on those 2 patients because they all present a stroke symptom as well as other neurological symptoms. And I want to show you another brain biopsy was done in this cohort. Clear, there are small micro and a thrombi. Those are 3 small vessels. And if you further magnify a little bit more, you really can see the endothelial cell was really altered, and you don't really see clear the vessel wall. And there's also a lot of it reactive endothelial kind of cell around the vessel. Those are really kind of suggesting those stroke patients, there's significant endothelial injuries. And then we really thought about what is really the mechanism, how this virus can cause a stroke. Well, as a first group reported all young stroke patients, But the second cohort, those patients also have a regular risk factor. So if you have a COVID-19, if you present all regular risk factor, you're probably going to present a stroke, maybe speed up a little bit. And then there's a systematic process, is immune response and cause inflammations and hypercoagulability, we just mentioned about it. And or the virus can directly invasion and into to the vascular systems, and it may affect the heart and actually cause a stroke, and and a direct invasion of the vessel will make the vessel relatively and easy to and a, and a, to burst, and it can cause an intracerebral hemorrhage. One of the big things is how we're going to treat those stroke patients, as a lot of them actually cryptogenic, means we really cannot pin down the etiology. And should we anticoagulate those patients since the D dimer is so high, and how long we should coagulate those patients? And then the International Society of Thrombosis and Hemostasis actually release some guidance how to recognize and manage those coagulopathy in the COVID-19 patient. Basically, if you D dimer significantly increase, and they basically recommend and you proactively to start anticoagulant on those patients. If I look at clinicaltrial.gov, there are several clinical trials, very large scale, and actually really look at how we're going to treat anticoagulant for this coagulopathy. And the NIH, I think they launched a very big called a master protocol and test a variety of regimens how we can anticoagulate those so the COVID-19 patient. Some they have stroke, some they don't have stroke. So we just talk about it is there clear as link between this virus and a stroke, but the COVID-19 is also affect in a stroke care on the larger scale. The first report is that, as you probably know, in the US or Europeans, we heavily use called rapid system to identify large vessel occlusion. And use this software, we actually able to record how many patients receive and this imaging software. Using imaging software, interestingly, they find it in the U.S. And once the national emergency was declared, and there's a tremendous decrease of the stroke volume, and almost by 40% once we get into this pandemic. This was very striking and a decrease of a stroke case. And similarly in China, where the virus first started, and then this is a national study with many hospital registers studies, and they observed a similar, and they find all the hospitals and look at stroke admission, and they saw almost in February, 25% decreasing, and just about the TPA cases, and for those thrombectomy, 23% decrease. Over admission, almost a 40% decrease, which is similar to the rapid and software usage in the US. And they divide the hospital by those designated hospital treated COVID-19 and also undesignated hospital treated for COVID-19, and they find a similar trend. It means it just stroke volume just decrease. And then they send a survey and they try to identify potential cause why the stroke care was affected. And then they ask the question, potential reason for pre-hospital delay. And they finally look at the most common one, is 87% responded to the survey saying, and the patient and their family fear of a contact virus in the hospital. They also try to identify potential reason for decrease in stroke care admission. the most common one is the same, and the families fear to come to the hospital. The potential reason for increased door-to-needle time is look at is because the COVID-19 screening process, because most of stroke patients, they maybe cannot talk. So they have to put the PPEs, put the precaution on. They actually delay the process treated with TPA. What about the potential reason for decrease of thrombolysis given TPA? Similarly, the number one cause is reduce the number of patients come to the hospital, okay? And also pre-hospital delay. You know, number one, there's not many. Second is there's delay because they fear to come to the hospital. What about those thromboectomy, endovascular therapy is really reduce the number of cases and hospital delays. Basically is, you know, patients are scared. Even they have a stroke, decide they don't want to come to and to the hospital for stroke care. Similar, this is a study published in Hong Kong, and it also shows onset to the door time has got a significant delay. Those are pre-hospital, and the door-to-needle time was not too bad. And so, and in Hong Kong, so I mean they did a really good job. Another report come from Italy, Lombardy, where it really and it was a severe effect. As you can see, and they have a significant and 173 patients, and it was includes a study. 6 was positive with COVID-19, and also 43 have a stroke, and about hospital mortality was almost 20%. So it's really big issues. And then there's a lot of patients present delirium, which I'm not going to get into, which I believe that Dr. Humble will talk a little bit more. Again, this report really show and a decreased activity for thrombectomy and increased care delay. So really affected the stroke care at a big time. And as this slides kind of show you, and as this a Canadian group put it together called a Protected Code Stroke. And the purpose of really protect the stroke patient, at the same time protect the medical staff, and also streamline the process to make sure the door-to-needle time is not a significant delay. So, and it's just a similar protocol in implemented at Duke Hospital, and we had a tremendous impact. We actually able to and improve our door-to-needle time. So, we spent a lot of time talking about stroke in the last about 20 minutes, but as I point out, and the COVID-19 is affected the neurological system, not just by stroke, and they can affect the patient with encephalitis, myelitis, ADEM, GBS, you know, as this slides kind of show you, you know, stroke probably happen maybe about a 7 day once you exhibit kind of respiratory symptom from COVID-19. So really, there's a wider spectrum of the neurological complication from the COVID-19. I'm not going to go through all the detail, but I really due to the time, but I do want to kind of point out is loss of taste and loss of smell is quite a common. Sometimes can be the only symptom, and once you infected with COVID-19, and there's actually MRI scan on this patient, and really show there is and there's a edema and with olfactory bulba, so clear there's some inflammation over there, and of course the patient lost their and smell. And once this patient getting better, you can see the edema but just resolve, and the olfactory bulba basically normalize. The good part is the majority of patients actually recover as they recover from the COVID-19. With this, I'll conclude here. COVID-19 is caused by severe acute respiratory syndrome, coronavirus 2. It can cause multi-system complication including neurological system. There is a possibility link between the virus and the stroke and other neurological complication. The mechanism still is not very clear, but we suspect coagulopathy is one of the possible mechanisms. There's a significant negative impact to the stroke care at a system level, and the neurologists need to be really vigilant and about a short-term and long-term complication from this virus. With this, I'll stop it here, and maybe I'll take a few questions.
Thank you, Professor Feng. Any questions, Victoria, for Dr. Feng?
We've got a couple, and actually Dr. Wilson said there might be further elaboration during her talk, but we have a question. Do we know what percentage of typical non-COVID admissions would develop these complications?
For stroke, it seems there are several cohorts, and it seems the percentage is about a 3 to 5%. So I think it's not as bad as we initially thought.
All right. Another one. And forgive me if I pronounce this incorrectly, can cachosmia be a symptom? One patient reports bad smell after febrile illness.
I haven't really received any case report about cosmia, or most of them actually anosmia, basically lost smell, but I'm not quite sure they can cause distortion of the smell. But based on the report I just presented to you, clear there's information associated edema associated or olfactory bulbar. Theoretically, it's possible.
Right. What do you think is the origin of Guillain-Barré positive COVID-19? Neurotropic mechanisms? Question mark.
That is, I don't have a right answer for this one, but they, Lancet Neurology published a review paper. The number of cases with DBS is still not many. It's harder to know, is this a coincidence or they're not, or there's a link. I think there's a possible link, but I don't have the answer for you right now.
All right. Does rehab processes have changes due to COVID?
Yes, I actually had one slide, but due to time, I have to take that slide out. Dr. Jeanette Bettinger from Duke actually in a published position paper and basically look at about 20 plus hospital in the worldwide, and then a lot of rehab services have to, particularly in the outpatient rehab service, have to be closed, and even the inpatient rehab process and service have to be downsized. So yes, it had a significant impact, and which I believe Dr. Hamburg will probably the second speaker probably can talk a little bit more. Yeah, on this.
All right. Is there a general consensus on mortality rates related to stroke across different countries? Is it potentially related to patient age? I'm not sure if they mean in the context of COVID positive patients as well, but maybe you could speak to both.
The mortality is clear as an increase for a patient with COVID-19. I personally take care of a few patients, stroke patients with COVID-19. Unfortunately, they had a very poor outcome. I'm not sure there's a consensus across the different countries. As we have more publications, we probably know a little bit more. Presuming the developing country, they may not have the mortality might be a little higher. And because even without a COVID-19, the mortality tends to be higher in some of the countries.
All right, we've got a chicken and the egg question. Is COVID causing stroke, or is stroke caused with an hospitalization acquired infection of COVID? So are they coming in with strokes, then getting COVID, or are they having COVID and then having strokes, or both?
Well, so clear there's a link between COVID-19 and a stroke, although we're not quite sure the mechanism, but we think a coagulopathy is possible. If you have a stroke, it affects your immune system, make you a little bit liable, but make you a little bit predisposed to COVID-19. So yes, and it's all possible.
Dr. Good, keep me honest on time here. How are we doing?
Yes, I think we should probably move ahead. Dr. Feng, excellent talk, and we really appreciate your answers to the questions as well.
Perfect.
So let's move on then to our next speaker. You've already met Professor Volker Homburg. He's the head of neurology and medical director of SRH Gesundheitszentrum Bad Wimpfen, Germany. Professor Homburg has had a distinguished clinical and research career. He's been the president of the German Society for Neurological Rehabilitation, and he's also been the Secretary General for many years of the World Federation for Neurorehabilitation. He was previously Secretary General also of the European Federation for Neurorehabilitation. He's currently the Vice President of that organization. He has many research interests. He has over 200 original articles. He's been a major factor in organizing many international congresses, including the 11th World Congress scheduled next October in conjunction with the French Society that you already heard about. The topic today is security aspects in neuropsychological rehabilitation during the COVID-19 pandemic. Professor Homburg.
Okay, David, thank you very much for the kind introduction. What I will try to do in the next 20 minutes or so is go a little bit over the clinical phenomenology concerning neurology on COVID-19 problems, and especially address problems of safety issues in inpatient and outpatient rehabilitation with a major emphasis on our main topic today, which is neuropsychology or cognitive function in connection with COVID-19 problems. May I have the next slide, please? Okay, we certainly have to see that COVID-19 is not the only disease in the world. And Wayne has also alluded to the fact that probably during this pandemic, we are sometimes neglecting other major issues. We have neurological problems which are related to COV-2 infections, but we also still have patients who are not affected with COVID-19 problems in rehabilitation. Nevertheless, they are possibly endangered to be infected during that period of their stay, for instance, in an inpatient hospital. I address both of these aspects. Next slide, please. Okay. We are dealing with these corona problems for a couple of months now. But nevertheless, we still are in a position that many questions cannot be answered yet. Although there is an enormous plethora of papers appearing day by day, also jeopardizing in some sense the peer review system in the world, because sometimes publications are put forward in a too fast and hasty way, which may eventually give wrong information to other world. Concerning the epidemiological features of the virus, we do not know very much about the speed of spread, the containment strategies which can be helpful. We do not know a lot about spread by non-symptomatic virus carriers. I'll come to that later, and spreading by aerosols versus just only droplets. Clinical phenomenology, we will see. Immunology is also not entirely clear. There are more and more antibody testings available, but the significance of this is really not pretty clear. And all of this brings us to the situation that we're still playing around and dealing with a scientifically not really completely understood problem. Next slide, please. Okay, the clinical phenomenology, Professor Wayne Fang already alluded to that, is a very broad one. Originally, of course, the primary clinical phenotype were people with lung problems and respiratory problems, but we have learned over these months that multiple organs are infected, and especially the central and peripheral nervous system is affected very much. Next slide, please. You see the SARS Cov-2 virus through ACE receptors can affect a wide variety of organs, including the brain, not just the lung. Next slide. And this was one of the first papers directing attention towards the neurologic manifestations in hospitalized patients in Wuhan, where all of this started, in a cohort of 240 people, and quite a lot of them had various neurological problems, including stroke, what Professor Wayne Fang already talked about too in general. But the situation is probably more complex. Next slide, please. Olfactory and gustatory dysfunctions are very frequent, and we have more and more learned to put that on the list of asking for possible subclinical symptoms in this problem. This was one of the first published in April of the first papers looking at a somewhat bigger cohort of people from an ENT perspective, and you see that above 80% of patients reported to have olfactory and gustatory dysfunctions if you go into more detail and ask them in a more direct way. Next slide, please. So we have a plethora of reported neurologic manifestations. We have all sorts of minor problems as vertigo and headaches. We have, on the other hand, also problems affecting cognition, affecting affect, as disorientation, agitation, and even disorders of consciousness. All of this may happen. Next slide. Encephalopathies have been reported early, mid-April in New England Journal, and they looked at a cohort of 58 patients, and with a fairly high percentage of people having encephalopathy problems. Next slide. Just recently, a couple of days ago in Brain, there was an interesting and very diligently clinical reporting on about 42 cases from University College Hospitals in London and the National Hospital there. And they found, next slide, about 5 major categories of neurological dysfunction in COVID patients. There were 10 patients who had sort of encephalopathy presenting with delirium and/or psychosis without distinct MRI or CSF abnormalities. The majority, 90%, made full or partial recovery at least. There was another cohort of 12 patients having inflammatory CNS syndromes, including various forms of encephalitis, and even like the neurological phenotypes mimicking multiple sclerosis or other demyelinating diseases. These patients responded, were treated with steroids and/or immunoglobulins, and most of them made at least partial recovery. Nevertheless, one patient in this sub-cohort died. There were 8 patients laying with ischemic stroke as the primary neurological presentation, possibly related to what Wayne has already mentioned, the hyperthrombotic state and the hemostasilitical problems related to the SARS infection. Nevertheless, 8 patients had a purely peripheral neurological symptomatology and then phenomenology resembling Guillain-Barré syndrome or other types of an acute inflammatory radiculopathy and plexopathy. So there is a wide variety of primary neurological disease forms and nosological entities which may be related to the COVID-19 problem. Next slide, please. Okay, nevertheless, I think we have to deal with the problem that also during the SARS pandemic, of course, there is a need for medical rehabilitation. That may even be increased due to COVID-19 related problems, but there are many patients who still need, of course, neurologic or general medical rehabilitation after operations, after stroke, after traumatic brain injuries. And the question is, can that be done in a safe way? And of course, we have to go on to provide rehabilitation especially for severely affected neurological patients after a variety of diseases, there will be an emerging additional need for care for post-COVID-19, recovered COVID-19 patients with neurological sequelae. We will certainly hear a little bit more about that and a lot more about that from the next speakers in this series. And the question is how this can be done safely without the risk of spreading infection, without the risk of spreading infection to therapists, without the risk of spreading infections through the rehabilitation setting. Next slide, please. Okay, I had a fairly painful experience. I'm director of one of the biggest rehabilitation spots in Germany, and recently, starting in early April, in a 400-bed inpatient rehab department, we encountered a really significant SARS outbreak. Although, right from the beginning on, that started in late February or early March, we were extremely careful, just by clinical inspection and by symptomatology, to isolate patients who were eventual candidates to be afflicted with COVID-19, doing all the general, symptom control measures, such as body temperature control, regularly, oxygen saturation measurements, and so forth. We isolated all symptomatic patients. The staff started to use surgical masks on normal wards and even higher quality FFP2 masks in rooms of symptomatic patients, and we closed the hospital early in March completely for visitors. Next slide. Nevertheless, in early April, we experienced that we had first staff members. They were the first. Staff members tested positive in the community, and also we then, a couple of days later, found the first positive testing patient. All patients who were tested positive had to remain isolated with regular symptom control and were, if necessary, of course, referred to the ICU if they had respiratory problems. By mid-April, we decided, together with the health authority bodies in the area, to test all patients and the entire staff. And we were surprised to find about 100 out of 200 patients tested positive, and also about 50% of the staff, 60 to 70% of patients did not have suspect clinical signs or symptoms. But nevertheless, that, of course, was the indication of a major outbreak. Next slide, please. Well, can we go back one? Yeah. Let me do a short resume from this outbreak. First of all, it was clear to us that it was not just sufficient to monitor clinical symptoms. Many patient staff had the virus, spread the virus, and had no symptoms whatsoever. They were not even oligosymptomatic. They had virtually nothing. The other message with the lesson is the virus is extremely contagious. And the only way to deal with that is repeated testing of the virus genome, otherwise you do not. Next slide, please. That was, in actual fact, I've seen this paper in PNAS a couple days ago, really corroborated from these authors who did a very diligent study published July 6th. Next slide, please. And it's about transmission by asymptomatic patients. And they found that the majority of incidents may be attributable to silent transmission. And even if you isolate what we did, if you isolate all symptomatic cases, nevertheless, virus outbreaks may nonetheless stop. Over 1/3 of the silent infections must be, if you do a modeling of this, you have to, over 1/3 of silent infections must be isolated to suppress the future outbreak. And symptom-based isolation as such, as the only measure, is not sufficient, but must be supplemented by rapid contact tracing and testing testing for the virus that identifies or may or not identify asymptomatic and pre-symptomatic cases. That is the bottom line of that. There is no way to ascertain safety in any respect without regular and repeated testing. Next slide, please. Okay, safety concepts. Well, of course, all of you are familiar with the general hygienic rules, which apply not only to COVID-19 problems, but our general regular hand hygiene and all of this. Nevertheless, you know, there has been a never-ending political discussion, and which is still going on in many parts of the world. What are safety measures which work? Next slide. Well, the question is, are masks useful? Masks have been used quite a lot. This is an old slide on the left side from India in the 1930s, showing believers in the Shvetambara sect of Jainism. And these people wear mouth masks all the time in order to avoid inhaling insects involuntarily. And they also have these brushes to avoid stepping on worms, because then it's completely forbidden to kill any animal in the world, any creature in the world. That is useful for masks, but are masks useful for prevention, the spreading of droplet or aerosol-related viral infection? And next slide, please. Well, there was an editorial in The Lancet in early March or mid-March, and they looked at the evidence at that time, and they also looked what was the prevailing policy on using masks. You know, President Macron is wearing masks already at that time, whereas President Trump is not really willing to wear a mask. Let's say how that developed. Yeah, at that time, next slide please, in mid-March, when you look at these suggestions from the WHO, suggestions in China, or let's say suggestions in Germany, you know, the German Health Authority came up with the idea there's not enough evidence to prove that the wearing of masks significantly reduces the healthy person's risk. And the idea was not to recommend mask wearing, because that may give a wrong impression of security or safety to people. So it's better not to have a mask, because then you're more careful. Looking back to this, that almost sounds ridiculous. But nevertheless, these were suggestions. The Center for Disease Control in Atlanta recommended that people who are well were facing and restricted it to people who had some sort of symptom. Right? Well, the situation in East Asia is a little bit different. Of course, there has been a long tradition in wearing masks for whatever reason. So that the bottom line at that time was, that is not such a good idea to use masks. Okay, let's go on. Victoria, next slide, please. Well, in Germany, at that time, starting in late March, certain communities started to make mask wearing obligatory in the community, inside and outside. And what they found was an immediate drop in the number of new infections after this mask policy was installed, which is, well, it's not evidence-based in a strong scientific sense, but it's a remarkable finding, nevertheless. When you look, next slide, please, at the evidence-based underpinning, there was an article by Derek Chu and others published in June here. And then what they did was to do sort of a meta-analysis concerning physical distances, face masks, wearing eye protection regimens, and to look from historical data, primarily in various other droplet-related infections, in how far mask wearing may affect this. And you see, even the American president more so slowly starts to wear a mask. Not always, but sometimes. So let's look a little bit at these data. Next slide, please. Okay, this is a forest plot from historical data. And you can see clearly that it's a good idea of various infections, various viruses, SARS, COVID-19, MERS, and so corona type of virus infections from historical data, of course, primarily, except for the one study in China with the COVID-19, there is significant evidence that mask wearing protects spread of the virus. Whatever mask you wear. We can go into this later. Next slide, please. No, go one back. The other problem is physical distancing. I think physical distancing is one of the, let's say, well, key. We ask patients and employers 1.5 meters or 2 meters distance. Is there evidence that? In actual fact, there is evidence that. May I have the next slide? This is also from this paper I mentioned in the Lancet on physical distance and another Derek Chu, and a very readable, good paper, which has been, it's probably in the month, within the next couple of weeks, last couple of weeks, the most quoted Lancet paper. Next slide, please. Okay, this is a forest plot on distancing. And here you can also see that by and large, there is an overall highly significant fact that higher distance is better than proximity. No doubt about that. So there is also, even if you look at apply the rationale of evidence-based medicine, there's clear and unequivocal evidence that distancing is used. Okay, next slide. This is let's say, a plot on the probability of getting spread infection depending on distance, and you can see roughly 1.5 meter and more, reducing that to critical minimum. And this is also from this meta-analysis, putting the data together. And I think there is really very good evidence that this distancing, very simple thing, that distancing is a very useful tool. Okay, next slide, please. Okay, coming from our experience with this outbreak, we developed a safety concept for, this is for inpatient rehabilitation, medical rehabilitation. We have neuromuscular, we have internal medical and primary neurological problems. These are just some ideas that nobody has to buy this concept really, but this concept is meant, first of all, to be efficient, second, also to be outlasting, in the sense that it can handle out, depending on the regionally different infectious situation, and it will always work. Let's go over some of these aspects briefly. Rigid control of general hygiene standard. Staff should use high quality masks, especially if they're working close to patient for more than 10 minutes and less than a meter distance. Patients should use surgical masks. Therapists should be marshaled to reduce as much as possible, which is important, reduce as much as possible one-to-one patient therapist contacts, and therapy and nurses for each contact should not, the contact time should not exceed 10 minutes. We have always claimed that today in modern neurological rehabilitation, in any case, there is a transition from going from hands-off treatment, hands-on treatments to more remote hands-off treatments. And of course, these rules, especially during this pandemic, in this pandemic time, should be followed. And Keep a distance of at least 1.5 meters between all patient-staff interaction, and patient-patient interaction. What I mentioned already. Next slide. Another major element is, of course, testing for the virus. The RNA PCR testing is absolutely essential in this respect. So all patients are tested in our places now, are tested on admission, and are, as long as we do not know the actual infectious status, after that isolated for a different number of days. The number of days between two negative tests is debatable. The maximum incubation period for SARS Cov-2 virus infections is about 14 days. So at the moment we stay roughly 14 days. So if there are no pre-testing, we keep people in an isolated condition as much as we can for up to 14 days before they go in a more liberal inpatient situation. We have, of course, a special section for positively tested COVID-19 patients. And so we separate the entire inpatient hospital to a clearing part where patients are isolated for a while, and to a non-COVID and free part where patients can be treated in a more liberal and less restricted way. Next slide, please. On these clearing non-COVID section, patients are regularly checked for COVID symptoms. Staff is also regularly checked, and we try to avoid as much as possible, it's not 100% possible, any crossing between sections. So we have 7 teams on the isolation, clearing wards, and special team on the free wards. Next slide. Okay, this webinar this afternoon is primarily on neuropsychological diagnosis and treatment, and as you've seen, there are a lot of cognitive problems, primarily cognitive problems and late cognitive problems, which may be related to COVID-19 problems. For neuropsychology, I want to allude to the safety aspect. I think it's important that neuropsych assessments and treatments certainly are very important in COVID-19 suspects, patient and recoveries, no doubt about that. All safety rules have to be followed to ensure maximal security for patient and clinicians. Whenever possible, distance should be kept as much as the situation allowed. Digital and tailored tools should be used as much as possible. There are quite a wide variety of them available. The COVID-19 problem will certainly stimulate the further development and spread of these tools. Group treatments should only be done with sufficient distance, and the group size should not exceed 4 patients or so. That's depending a little bit on the size of rooms. Inpatients who are quarantined for longer period need additional psychological support. That is a very important issue. If you keep and ask people to stay in their rooms in an inpatient setting for 10 days or more, of course they need a parallel psychological support. And of course, whenever possible, decent RNA PCR testing should be used in patient health. Next slide. Next slide, please. Yeah. At the moment in Europe, there is some sort of enthusiasm in the sense that people say, well, the number of new infections today is very much decreased, and we are almost done with the situation. I think that is definitely not true. If you look at the international figures, the situation looked quite different. This was a recent editorial about 2 weeks ago from the editor of The Lancet, really stating USA, Brazil, and India have 100,000 or more new cases after June 26. And when you look at more detailed things, you come at the end, and I think this is a very important statement, which we should always have in mind, that much of the globe the worst may be yet to come. And sometimes people are talking about a second wave, whatever a wave will mean. The point is the virus is present all the times. There may be regional differences in its contagiosity or in its importance, but it's there. That is not a new wave coming. It's the same virus all the time, more or less. Okay, that is all I wanted to talk about. Thank you very much for your kind attention, and I'm more than happy to answer questions. Thank you.
Thank you very much, Professor Homburg. Very enlightening lecture. We're a little bit short of time, but I think we have opportunity maybe for a couple questions, Victoria.
Yeah, absolutely. I'm also going to launch a poll really quickly if everyone would have a chance to just fill it out as at your earliest convenience. But let's go ahead and move on to the questions. So Dr. Homburg presented evidence regarding the effectiveness of social distancing and mask use. Is there similar evidence regarding the time of interaction and more specific guidelines about it, i.e. limiting interactions to 10 versus 30 minutes?
Well, there's not really good data on this available. So that is more or less a rule of thumb that we say 10 minutes or 15 minutes of less than 1.5 meter contact is critical for a possible spread. But there's not good data on this.
Okay. Should the same safety rules be applied to academic settings in which we are training healthcare professionals, assuming that students may be asymptomatic or pre-symptomatic?
Well, certainly, you know, that doesn't the virus doesn't make a difference between that. Well, the testing is essential. Without testing, you don't have any idea. You see that 60 to 70% of the virus spreaders are non-symptomatic. You cannot rely at all on just monitoring symptoms. We do symptom monitoring day by day in our staff, you know, in the morning when they come, and then in the afternoon when they go, we check their body temperature. We ask them if they have a cough or a running nose or something like this. This is probably not really necessary to do. If you test them regularly, that's probably much better.
All right. Specific about some of the data you presented, in the 400-bed rehab hospital that had a high percentage of patient or /staff whom tested positive, were patients wearing masks as well, or were just the staff in that hospital?
When we did, that was mid-April, when we did this testing. The decision was, we were discussing this, we had some first cases, and we had some positively tested staff members who were tested in the community. Okay. And then we made a decision to test all of them, just to get an idea. And what we realized was that we already have a tremendous virus spread. Although the majority of these people, various parts of the hospital, were non-symptomatic. That was, well, we were surprised to some extent. That gave us a hard time. We put the entire building under quarantine for weeks. And of course, we kept the people in, and then, if possible, with retesting and so forth, we sent them home. But nevertheless, we had to restart. Imagine the entire service again with a very strict safety policy.
Right. I think maybe one more, Dr. Good.
Yes, just one more, please. Yeah.
So someone asked, I've been carrying on a post-COVID rehabilitation program on their hospital's clinic. They've been receiving patients 15 days after discharge from the hospital. They're concerned about the patients still being contagious, so they're still using PPE and 95 glass masks, gloves, etc. Do you think it's necessary to continue precautions after discharge from the hospital?
That is a good question. You know, what masks you use is depending what you are hitting for. The FFP2 and 95 masks are good to protect the therapist or the person dealing with the patient. For, let's say, control the probability of spreading, surgical masks or other self-made textile masks are sufficient. That is a difference which you have to keep in mind. If you discharge a patient from your inpatient setting and you don't know about the infectious status, it's certainly a good idea to recommend them to use whenever they are in contact, and only if they are in contact with other people, not at home when they're alone, not when they're sitting in the car alone. That doesn't make sense. To wear a mask. And I think it is really important worldwide in the community that mask wearing is useful when you're dealing with closer contact to people. Not really if you go on a walk and you have at least 1.5 meter distance outside, that there's no need to wear a mask. But when you go in a supermarket or go to any other sort of shop, and especially when you go to let's say, gatherings of any sort, distance keeping and the mask are absolutely essential.
All right.
I think we'll move on. Thank you, Victoria. And thank you again, Professor Homburg, for your lecture and the answers to the questions. I'm going to introduce our next speaker. Barbara Wilson is a clinical neuropsychologist who has worked in brain injury rehabilitation for 42 years. She's a renowned expert in her field. She's published 29 books, 203 peer-reviewed papers, and 123 chapters. She's received many awards for her work, far too many to list here. She has held 30 research grants, and her work has resulted in changes in clinical neuropsychology practice. She is a chair for all of the special interest groups for the World Federation for Neurorehabilitation and a member of the Presidium. She's been invited to speak internationally on multiple occasions. She's a passionate speaker who's very devoted to her work. We're very, very fortunate to have her speaking to us today. And her topic is neuropsychological consequences of COVID-19. Professor Wilson.
Thank you very much, David. I hope everybody can hear me okay. Victoria, can they hear me all right?
We can hear you great.
Good. So this is the neuropsychological consequences of COVID-19. I should point out I'm the only non-medical person speaking today. I'm a clinical neuropsychologist, so I'm more concerned with the hands-on rehab. But this work is carried out with a number of British neuropsychological colleagues, Jessica Fish, Hugh Williams, Jonathan Evans, Shay Bettridge, Audrey Daisley, Bonnie Kate Dewar, Gabby Parker, and Ava Easton. Now we know that many organs can be affected by this virus, including the lungs, heart, blood, digestive system, and the brain. And the virus can directly affect the brain. The mechanisms by which this occurs are not clear. It could be a direct cause or a secondary effect, or indeed both. And because there's evidence of the virus being found in the cerebral spinal fluid of patients, this suggests a direct cause. And of those who are rendered severely ill, some of them are going to go on to develop hypoxic brain damage, encephalitis, stroke, multiple sclerosis, or epilepsy. And thus they may have problems that require a referral to a neuropsychologist. Now, how many people are affected and how long do symptoms last? I know this was one of the questions that we had earlier. Well, the numbers vary, as we've already heard. In other coronavirus cases, not the COVID-19, but other coronaviruses, of those admitted to intensive care, 70% of them needed ventilation. And of these 70%, 78% had cognitive problems 1 year post, and half of these had problems 2 years post. And one study found self-reported memory problems 5 years post, with the kind of problems people were reporting being forgetting to take their medication and forgetting hospital appointments. And in MERS, the Middle East respiratory syndrome, 70% of them showed psychiatric symptoms, both psychosis and hallucinations. Now, in this virus, we know that encephalitis and stroke can occur. And in one British study, looking at 153 patients, they found 6 of COVID-19 patients admitted to hospital are likely to develop encephalitis. And a recent email from Ava Easton, who's been involved in this work, said there actually may well be more than 6%. We know that strokes are not infrequent, and these can be both ischemic and hemorrhagic. And this is from a webinar by Elkanon Goldberg, in New York. He said in the United Kingdom, hemorrhagic strokes are seen in patients in their 50s to 80s, while in the USA, ischemic strokes are reported in younger people in their 30s and 40s. And indeed, COVID-19 may present as a stroke, and that's reported by Avula et al. In Press in 4 patients in the United States. And Feng, this is our own Dr. Wayne Feng. This is from the previous webinar. He said that 1 in 4 people admitted to hospital have CNS involvement, but only 3% had a stroke. I noticed today he said 5%, so well, the numbers do vary. And that COVID-19 can cause sudden strokes in young people with no risk factors. Now, I hope I've got this right, Wayne, but in your previous webinar, you made this interesting point to me when you claimed that all COVID-19 stroke patients died in hospital, while only 10% of other stroke patients died there. And in general, there is a higher mortality rate if COVID-19 patients are admitted to hospital with neurological symptoms. Now, this is the big British paper, the 153 patients, that's been very important here. So they looked at 153 people seen in British hospitals. I think this was the first big paper to come out from the United Kingdom. And they found that cerebrovascular events predominated in older patients. Conversely, altered mental status, while present in all ages, had a disproportionate representation in the young. Encephalopathy, I know the Americans say encephalopathy, but the Brits say encephalopathy. Well, that's relatively common, being reported for 93 patients in total, including 16 or 7.5% of 214 hospitalized COVID-19 patients in Wuhan, China, and 40 or 69% of 58 patients in intensive care with COVID-19 in France. And there's some overlap of these figures from the previous 2 speakers. And encephalitis has been described in 8 patients to date, and Guillain-Barré syndrome in 19 patients. SARS Cov-2, that's the COVID-19 virus, is detected in the cerebral spinal fluid of some patients. So those who've spent a long time in intensive care may be left with lasting cognitive impairment. And that's not to mention the possibility of long-term emotional consequences, such as anxiety, stress, depression, and insomnia. And of course, there are high levels of anxiety and stress in the carers too, and many clinical psychologists are already dealing with those issues. But all of these problems are typically assessed and treated by neuropsychologists. Now, look at all these problems: motor problems, sensory problems, cognitive problems, behavioral problems, social problems, emotional problems, pain, fatigue, and so on. That's all what we would expect to see in rehabilitation centres from people with acquired brain injury. So these are problems faced by survivors of brain injury, but they also seem to be faced by survivors of COVID-19 too. Well, they look as if they are at the moment. Now, the hippocampus seems particularly vulnerable to the coronavirus. And of course, that means there's going to be an increased chance of memory problems and an acceleration of disorders such as Alzheimer's disease. There's been some studies with mice confirming hippocampal involvement, but the cognitive problems reported in people who've survived COVID-19. So of the cognitive problems we see, memory, attention, executive deficits, verbal fluency problems, slowed information processing, and speech and language problems have all been reported. That was a paper recently come out by Richie Chan and Walter Meyer. Now, this is one I've been involved with. An Indian colleague, Jawala Narayanan, has also reported a 62-year-old patient who developed COVID-19, then had a stroke and was left with Baylis syndrome. That's now in press, and we think it's the first COVID patient reported with Baylis syndrome. So what is Baylis syndrome? Many of you will never have heard of it. It's very rare. So it's a rare syndrome, and it's comprised of 3 components, namely psychic paralysis of gaze or optic apraxia, which is an inability to look voluntarily into the peripheral field. The other component is optic ataxia, which is an inability to localize in space or manually point to visually presented objects. And when you're doing a clinical assessment, this is often the first thing you pick up. People cannot localize in space. And the third component of Baylis syndrome is simultanagnosia, where despite adequate visual acuity, it's impossible to process more than one visually presented object or stimulus at a time. So you show them 2 objects and they only see one of them. A rehabilitation is essential for these patients, as we heard from Volker Homburg. All of the above reports and observations suggest that many survivors of COVID-19 are likely to require neuropsychological rehabilitation. And at present, that's severely underfunded, certainly in the UK and in many other countries too. I think the only countries where you get good funding for rehab are the Netherlands and maybe some of the Scandinavian countries. This is a recent paper from the British Society of Rehabilitation Medicine entitled Rehabilitation in the Wake of COVID-19, a Phoenix from the Ashes. And the authors stress that rehabilitation is critical, and they summarize some of the problems we might expect when trying to offer this rehabilitation. They do touch, this is a paper written by medics, of course, it's the British Society of Rehabilitation Medicine, but they touch on clinical psychology and neuropsychology when they discuss the importance of multidisciplinary teams. But they don't stress the importance of neuropsychology when dealing with the cognitive issues, which of course is one of the areas we specialize in. Now, these are some of the challenges that this paper say we face in rehab. COVID-19 patients will provide a great challenge to the existing structures of rehabilitation. Many COVID-19 patients will need local, community-based rehabilitation services, which are weak and often transient. Most attention is paid to nationally funded, highly specialised level 1 patients, that's the severely ill ones, and inpatient services, which see only a very small proportion, estimated at 1% of all patients needing rehabilitation. And many of the COVID-19 survivors are going to be the walking wounded. They may have some motor problems, but they're not the level 1 patients. For example, patients who have multiple sclerosis and quite severe complex disability requiring specialised services often cannot access rehabilitation. National specialised commissioning does not consider such patients, certainly they don't in the United Kingdom, and local clinical commissioning groups often do not support the expert rehabilitation service needed. This is that same paper, British Society of Rehab Medicine. COVID-19 has challenged all healthcare, including rehabilitation, and will continue to do so for at least a few years. COVID-19 has precipitated rapid change and adaptation. It could precipitate a long-needed change in the attention paid to rehabilitation, leading to a much better organisation and system of funding to allow more efficient and effective use of resources that are currently working in a fragmented, inefficient way. And this, if this change does come, this will benefit all patients and all parts of healthcare, so a phoenix may yet arise from the ashes. There's also these long-term mental health repercussions in health workers. And there's a suggestion that survivors of COVID-19 are at greater risk of developing Parkinson's disease later in life. So that's something we should be watching out for. And it can accelerate other neurodegenerative conditions such as Alzheimer's disease. So to summarize the neuropsychological aspects, we do expect many patients are going to require rehabilitation. And we need to follow up with regard to neuropsychology. We just don't know how many there are going to be at the moment. But those who have the acute respiratory distress syndrome exhibit a high prevalence of cognitive impairment, often persisting for months after hospital discharge. This is Mike Dilley, who's a neuropsychiatrist from St George's Hospital, and he says we should build a neuropsychological database of UK coronavirus disease cases and use a standardised, longitudinally repeated data, which is clinically and geographically inclusive. Now, rehabilitation as understood by neuropsychologists and OTs and speech and language pathologists and others doing holistic rehab, we see it as a process whereby people who are disabled by injury or disease work together with professional staff, relatives, and members of the wider community to achieve their optimum physical, psychological, social, and vocational well-being. And neuropsychological rehabilitation is concerned with the amelioration of cognitive, emotional, psychosocial, and behavioural deficits caused by an insult to the brain. And what about the long-term consequences? We just don't know how long the cognitive and emotional problems will last in those people that have them. We need long-term follow-up studies. So these are the conditions that may be referred to neuropsychology after COVID-19. Encephalitis, multiple sclerosis, Guillain-Barré syndrome, perhaps less often they get referred to neuropsychology, but they sometimes do. Stroke patients that we've already heard about, hypoxic damage, epilepsy. So these are the kinds of conditions that may get referred to us, and the kinds of cognitive deficits most often reported are memory, attention, and executive problems. They come up very frequently. But verbal fluency problems, we've been finding that at St George's Hospital. Slowed information processing, yes, many of them have that. Some have speech and language problems, high-level language problems maybe. Baylis syndrome, rare, but we've already heard of one case with that. And other visual perceptual, visual spatial deficits. The emotional psychiatric problems we may be faced with are depression, anxiety, post-traumatic stress disorder, psychosis, hallucinations. These have all been reported. And in the long term, hypoxia, encephalitis, and stroke are likely to cause problems seen by neuropsychologists. And those who spent a long time in intensive care are sometimes left with lasting cognitive impairment. So there's the possibility of long-term neuropsychiatric consequences. So we know that levels of anxiety, stress, depression, and insomnia are higher in psychiatric problems that develop COVID-19. And I'm just going to briefly finish with our study at St George's Hospital. So that's led by me, Jessica Fish, and Shay Betteridge, three of us there. And we feel there appear to be three groups of COVID-19 patients. There's those with the primary diagnosis of COVID-19. They've been fine before. They develop neurological conditions such as encephalitis, stroke, and hypoxic brain injury. So that's one group. Then there are those who've been admitted to hospital because of a neurological condition, so say a stroke, and then in addition, they've become unwell with COVID-19. And the third group are those who've got a pre-existing neurological condition, such as Alzheimer's disease, and they've been hospitalized for COVID, but the condition they originally had has got much worse. So we think these are the three main kinds of patients we're seeing at the moment. And we're conducting this audit in an attempt to characterize the neuropsychological needs of the people with COVID-19 seen within our department. And we're going to use routinely collected clinical data at assessment and through any rehab program and at clinical follow-up. And our specific audit questions are, what are the reasons for referral of patients with COVID-19 to neuropsychology? I mean, what's coming out there are they've been referred mostly for cognitive problems and mood problems. They're the two main reasons for referral. What, if any, cognitive difficulties are they experiencing? These are the ones I mentioned earlier. What, if any, behavioural difficulties are they experiencing? And what, if any, emotional difficulties are they experiencing? We also want to know what the functional impacts of these difficulties are. And are there differences between these three groups we've mentioned, in terms of demographics, cognition, behaviour, and emotional well-being? And do these difficulties persist or resolve over time? And through this audit, we hope to be able to better understand the needs of this patient group, to inform the service we provide for them, and to share this knowledge with colleagues. We're also engaged in an international collaboration, looking at the same kinds of questions with Brazil, Chile, Colombia, India, Iran, Italy, Spain, and Israel and the USA, one person in the USA, because, well, reasons I won't go into here. They're both thinking about, Israel and USA are thinking about it. Now, there have been, the most active of these people are Italy and Caterina Pistarini. And for the man who was asking the question about numbers, I think Caterina Pistarini would be a good person to email about that. But Caterina and her group have sent in some preliminary data. So Caterina, Elena Maria Fiabene, Claudia Vassallo, Elisa Howdy, and Federica Alemano. Now they've got some interesting preliminary results. They have two groups of COVID patients. Group one are the ones who assessed while they have COVID and they've had a test to diagnose this. And group two are the ones who've recovered from COVID and are no longer positive. But anyway, in group one, those are the ones tested while they have COVID. They used the mini mental state exam and found nearly 24% of their sample showed an impaired total score. It's actually quite high. And it seemed to be language and attention maybe where they were showing problems. But there were no post-traumatic stress disorder symptoms. I think these people are just too ill to be engaged in post-traumatic stress. Now in group two, that's the ones who've recovered, the mini mental state, they were normal. It's a very easy test, the mini mental state, but they were all fine there. But on the MOCA, that's the Montreal Cognitive Assessment, there was mild cognitive impairment for all of them. And there were difficulties in visual spatial abilities, possibly executive functions, and in a delayed recall subtest, a test of declarative memory. And that was confirmed by a story memory test. So executive functions and declarative memory are evaluated by the MOCA. And a significant part of the sample showed post-traumatic stress disorder symptoms. So almost half of them really, over 46%, and half of them showed depressive symptoms. So that's the preliminary results from Italy. So please don't forget the importance of neuropsychology. Especially for the medical people watching, it's a crucial aspect of rehabilitation. There's various references there, which I'm not going to go through now, but I think these slides will be available online so you can look at the references. And thank you very much for your attention. and I'm wearing my mask, look. Thank you.
Thank you very much, Professor Wilson. Excellent lecture. We enjoyed it very much. We have time for a few questions, I think. Again, we're running a little short on time. Victoria?
Yeah, absolutely. So we do have a lot of questions. Give me one moment. All right. May I ask, do you believe that the pathways for referral that currently exist in the UK are able to facilitate neuropsychological formulation and rehabilitation in relation to COVID-19? Or do new specialist services need to be developed?
I think some centres, like St George's, are trying very hard to do this, but other people are totally ignoring it. And you've heard of the postcode lottery, and I think that's happening here too. We do need, and there's a group organised by the British Psychological Society, and I hope this pathway will develop through them too. But I mean, it's an interesting question, and I'm more than happy for you to email me afterwards and discuss this further. I don't know if you're based in the UK or not, that person.
Okay. Another person from the UK, a psychologist working largely with older people. They'd be really interested in your thoughts about how clinical psychologists and community mental health teams / memory services who are already working with clients post-COVID now, but don't necessarily have access to specialist neuropsychology / rehab services, can link in with specialist colleagues to learn and work together to best support this client group.
Yes, I do believe in working together. I mean, it's hard to get a neuropsychological person involved, I know, throughout the United Kingdom and certainly in other parts of the world too. Sometimes the OTs do a very good job. I work closely with occupational therapists, and they're often the port of call if you can't get neuropsychology. Some speech and language therapists do. But again, if you're based in the UK and want to contact us, please email me, and I'd be more than happy to link you in with various people here that might be able to answer the question better than me.
Okay. We have one more specific to the MoCA. I'm not sure what the question might be asking, but it's what about MoCA impairment in cerebral imagery? I'm assuming for post-evaluation of COVID.
Well, I don't know about imagery because it's very difficult to get it when you want it for the patients we have. And what with all the problems now with getting them in the scanner and the personal distancing, you know, I think I'm not so sure what to say about imaging. I'm more skeptical about its value for rehabilitation than other people might be. And with regard to the MoCA, I think of the screening tools, the MoCA is probably the best available, but with many of these people, they need a more detailed and thorough neuropsychological evaluation. And that can be done from a distance. The St George's people, they're mostly seen in the hospital with people wearing protective equipment, but I've been assessing some patients remotely, and so it is possible to do that too.
Excellent. We are short on time. I am going to send out the questions to our speakers to have them answer any others offline, and we'll be sure to include that in the email that goes out to all of the current attendees. So don't worry, we'll try to answer your questions even if we don't get them today. But I am going to share the results of the poll if Dr. Good wants to review them really quickly.
Okay, let's see. Looks like interesting. This is what the continent you come from. 20% North America, 10% South America, 41% Europe, 15% Asia, 9% Africa, 3% Oceania, and 3% other. What is your age group? Can we scroll up on that?
So you'll have to scroll on your end, Dr. Good.
Okay.
You should be able to just scroll.
Great, thank you. I'll do that. Yep. So jumped ahead too far. What is your age group? Let's jump in here too far. Let me just see what we can do here. Sorry. Okay. Actually, it's not.
Go ahead and
Actually, can you read?
I'll review them on my end. That's fine. So what is your age group? We've got about 15% less than 30 years old. The majority is 58% between 30 and 49 years old. 19% is between 50 and 59, and 8% above the age of 60. For the professional categories, we included as many as we could. We apologize if we left anybody out, but physical therapists make up about 22% of the audience, occupational therapists, 15%, neurologists, 6%, physicians, other subspecialties, 8%, speech language pathologists, 5%, researchers, 6%, neuropsychologists, with the majority at 23% of our audience today. Student or trainees, we've got 5%, and other is 11%. Have you had experience taking care of COVID-19 patients in the last 6 months? 43% said yes, 50% said no, and 8% said not sure. And the last one's regarding our future World Congress of Neurorehabilitation events, particularly this one in October, and the willingness to contribute to support that kind of event a little bit financially. But I think that's it. I'm going to go ahead and stop sharing that.
Thank you, Victoria. Appreciate that.
And while you introduce, I'll get the next slides up and running.
Okay, before we introduce the last speaker, I would mention we are planning tentatively at least one more webinar, maybe more. The next one we're thinking about would be rehabilitation with COVID-19 in the developing world. And again, we don't have a date for that yet, but stay tuned. We're hoping that that will be one of our next webinars. All right, the last speaker for today is Professor Stephanie Clark. Professor Clark is the professor and head of the Neuropsychology and Neurorehabilitation Clinic at the University Hospital of Lausanne, Switzerland. The clinic provides neurorehabilitation to inpatients and outpatients in the post-acute and chronic stages of brain lesions, with particular emphasis on neuropsychology and speech therapy. She her research group studies cognitive functions and the functional reorganization of the cortex. Dr. Clark has had a number of important positions, including president of the Swiss Society for Neurorehabilitation, president of the Swiss Society of Neuroscience. She's been president of the World Federation for Neurorehabilitation and currently the past president. She serves on the presidium of the WFNR. She speaks widely internationally. She has over 150 original papers, proceedings, and book chapters. And her topic today is cognitive impairment from COVID-19, the impact on rehabilitation. Professor Clark.
Victoria, can you put on my slides? Thank you very much.
Yes, we're going to go ahead.
Yes, please. Hello, we are here at the CHUV, the University Hospital in Lausanne in Switzerland. I am the head of the Service of Neuropsychology and Neurorehabilitation. Our mission is to provide neurorehabilitation for in- and outpatients with special focus on cognitive diagnosis and rehabilitation. The cognitive part of our work is also carried out in the acute wards of the University Hospital. We have experienced a wave of COVID-19 in March and early April. During that period, over 5,000 patients were diagnosed with COVID-19 in our canton. Over 500 were hospitalized at the CHUV. After the acute period, 2/3 returned home and 1/5 were transferred for rehabilitation. Our service has been involved in the cognitive evaluation of these patients during the acute stage while they were in the internal medicine wards. For those who returned home, we have a cognitive follow-up in our outpatient clinic, and we set up an inpatient neurorehabilitation program for COVID patients, followed by an outpatient clinic. This work relies on a large team of collaborators. I would like to acknowledge my colleagues who coordinate the evaluation and rehabilitation of COVID patients at different stages. Valérie Beau for cognitive evaluation in the acute stage, Laurence Val for cognitive evaluation at the post-acute outpatient clinic, Dr. Stefano Carda in our service at the CHUV, and Dr. Pierre-André Rapin at our partner institution at Lavigny for inpatient neurorehabilitation, Valérie Anti in our service, and Estelle Jacques at our partner institution at Lavigny for inpatient post-acute cognitive evaluation and treatment. We have close collaboration with the Service of Neurology and the Department of Internal Medicine. My colleague Stefano Carda has published, together with Italian, British, French, Belgian, Dutch, American, Portuguese, Spanish, Canadian and German colleagues, a review and position paper on the rehabilitation of COVID-19 patients. The severity of COVID-19 is mainly defined by pulmonary involvement and metabolic consequences. Early on, the Chinese National Health Commission defined thus 4 forms of COVID-19: mild, moderate, severe, and critical. As pointed out by our colleagues in their publication, the rehabilitation does not concern only respiratory sequelae, but at least 6 other domains. Well, in summary, the need for rehabilitation is for the following points: respiratory sequelae, motor and cognitive deficits, deconditioning, critical illness related myopathy and neuropathy, dysphagia, joint stiffness and pain, and psychiatric problems. Several aspects concern neurorehabilitation, including cognitive aspects. The aim of my talk is to highlight the intertwining of cognitive deficits with other types of sequelae and their impact on rehabilitation. Let's look first on the acute stage of COVID-19. The severe form of COVID-19 is characterized by the acute respiratory distress syndrome, which requires oxygen supply and mechanical ventilation. When weaned from mechanical ventilation, patients tend to present neurological deficits. In an early report from Wuhan, Mao and colleagues reported impaired consciousness, skeletal muscle injury, and cerebrovascular disease in their patients. This was more frequent in severe than non-severe pneumonia. Helms et al. Have reported that patients after RDS, which required mechanical ventilation, and when they were examined after the stop of sedation, presented in 67% agitation and confusion, 67% cortical spinal tract signs, and 33% dysexecutive syndromes. Both studies highlighted acute confusional state. In both series, authors reported cases of acute ischemic stroke. A series of studies has reported ischemic stroke in association with COVID-19. A Chinese study by Mao and colleagues reported that stroke is more common in severe than non-severe COVID-19. They found it in over 5% of severe COVID and only in 0.8% in non-severe COVID. A British study by Beiruti and colleagues reported 6 cases of large vessel occlusion. An American study by Oxley and colleagues reported 5 such patients. Then a Chinese study by Li and colleagues again reported frequent acute ischemic stroke in COVID-19 patients. And at last, there are 2 American studies reported by Moshaedi and colleagues and Avula and colleagues reported further cases. In summary, the current evidence highlights the occurrence of acute confusional state in severe COVID-19 after weaning from a mechanical respiration. And there is this occurrence of large vessel stroke. Well, this points to a great need for cognitive and neurological follow-up in severe and critical COVID-19. Are there cognitive deficits in post-acute stage of COVID-19 which persist? What are the brain lesions associated with those? What is the impact of cognitive deficits on activities of daily living? And what is the need of cognitive rehabilitation? These are the questions which we will need to answer in the following months. There is another outstanding issue, which is the cognitive evaluation in moderate COVID-19. This is currently underrepresented in the studies. In addition to this purely cognitive aspects, there is the occurrence of anosmia and ageusia in COVID-19. Olfactory and taste dysfunction is frequent in COVID-19. Le Chien and colleagues have published a very large study on 417 patients with mild to moderate COVID-19. The disease was characterized by cough, myalgia, and loss of appetite. 85% presented olfactory dysfunction, and in 11% this preceded other symptoms. It is interesting to note that the recovery rate of olfactory dysfunction was 44%. In this same series, 88% of patients presented gustatory dysfunction. The study of Giacomelli and colleagues was cross-sectional and included 59 of the 88 patients hospitalized at that time. 33% of patients presented olfactory or taste disorders, and 18% presented both. Jan and colleagues published again a large study which included 1,480 patients with influenza-like symptoms who were tested for COVID. Of those, 102 were COVID-19 positive, and of those, 59 were tested. From those who were tested for taste and smell, 68% presented smell loss and 71% taste loss. 1,379 patients were COVID-19 negative. Of those, 203 were tested for smell and taste. And of these 203, 16% presented smell loss and 17% taste loss. This study illustrates extremely well how specific the smell and taste loss is for COVID-19 infection. Well, why should we be interested in anosmia and ageusia when we talk about cognitive deficits? Some authors have proposed that these problems may be linked to a first infection or entry to the central nervous system. Well, for the moment there is no precise evidence, but we need to keep in mind. The follow-up of COVID-19 patients during the post-acute stage is now being carried out, and we have really relatively few data. There are very important issues, and it becomes very clear that we have a real need for cognitive follow-up. We need also to follow up not only the severe cases of COVID-19 with the acute respiratory distress syndrome. We need also to have a cognitive assessment of non-severe cases of COVID-19. There should be a very well-defined use of comprehensive batteries of cognitive tests, and we need brain imaging to be included, not only because there are cases of stroke, but also that we do not really know what the correlates of the cognitive deficits are which we observe clinically. But what can we expect for this post-acute follow-up of COVID-19? Well, we have to look into other similar conditions, and I will very briefly address this issue with acute respiratory distress syndrome of other etiologies, and then the publication on SARS and MERS. There is a large number of studies on the outcome of patients who have sustained an acute respiratory distress syndrome of different origins. Our colleagues in intensive medicine are very much interested in this. I will quote two reviews. First is by Wilcox and colleagues and was published in 2013. It is a very detailed review on 34 original studies. And in summary, at hospital discharge, 70 to 100 patients, percent of patients presented cognitive impairment after the RDS. At 1 year follow-up, 46 to 78% presented still cognitive impairment, and after 2 years, it was 25 to 47%. The cognitive impairment concerned mostly attention, memory, executive functions, and the poor cognition was associated with white matter atrophy. Most of these studies included in this review did not distinguish between the presence or absence of prior cognitive impairment, and this question remains open: how much prior cognitive impairment contributes to the cognitive outcome after RDS. A second study was published by Herridge and colleagues. Again, it is a high-quality review which reports on the recovery and outcome after the acute respiratory distress syndromes, and again, etiologies other than COVID-19, of course. There is a very detailed part of this review on pulmonary, neurological, cognitive and mood outcomes. 12 studies which are included in the review concern cognition, and they report attention, visual spatial abilities, declarative memory, executive functions being impaired in the long run. But again, in most of these studies, there has been a number of patients with prior cognitive impairment. They were not excluded. Herridge and colleagues point to the multifactorial origin of this cognitive impairment, which is related at least partially to the duration of hypoxemia and to metabolic factors. This same review by Herridge and colleagues, published 2016, reviews also the mood disturbances which occur in RDS survivors. Again, it's other than COVID-19. They point out the frequent occurrence of post-traumatic stress disorder and of depressive and anxiety symptoms. Mood disturbances can persist for a relatively long time. At 2-year follow-up, 41 of the patients in many studies presented moderate to severe depressive syndromes, and depending on the study, 22 to 44% had post-traumatic stress disorder. At 5-year follow-up, moderate to severe depressive symptoms were still present in 19% of patients. The outcome of survivors of the previous coronavirus infection of the severe acute respiratory syndrome has been reported by Tansey and colleagues from Toronto. They report on 117 survivors at 1 year after hospital discharge. The pulmonary function measures were in normal range. However, 18% of patients had a significant reduction in distance walking, the 6-minute test. 17% did not return to work, and 44% had psychiatric and psychological follow-up. Rogers and colleagues compared the outcome of SARS, the severe acute respiratory syndrome, and MERS, the Middle East respiratory syndrome, with what is known now about COVID-19. In the two former, SARS and MERS, they reviewed 65 studies. During the acute illness, these studies report depressed mood, anxiety, impaired memory, and insomnia. There are reports of steroid-induced mania and psychosis in SARS. In post-illness stage, there are reports of depressed mood, irritability, memory impairment, fatigue, post-traumatic stress disorder, depression. It is interesting to know that the return to work on average was possible only after almost 3 years. However, it has to be noted that there is a very large variability in this return to work. As pointed out by Stefano Carda and his colleagues in their review, rehabilitation of post-COVID-19 patients needs to address several issues, and here is again the list which I have already discussed before. The primary problems are often pulmonary, but there are several domains which concerns the nervous system. The neurorehabilitation part in post-COVID-19 situations concerns the motor and cognitive deficits, the deconditioning, critical illness-related myopathy and neuropathy, dysphagia, and psychiatric problems. Well, it is very obvious that this needs to be an interdisciplinary approach with close collaboration. It also requires frequent assessment, especially on the cognitive part. Different types of deficits may recover at different rates. This is at least our experience in Lausanne. We have patients who recover one aspect or the other relatively rapidly, while other deficits may persist. As I mentioned earlier, there are few data on the mild and moderate forms of COVID-19, and we need evaluations. We need evaluation on the cognitive part, but also on the motor part. There are surprises which we notice here in Lausanne in both aspects. And for patients who have persisting deficits after the acute stage, we need in- and outpatient neurorehabilitation programs. Cognitive rehabilitation is a very important part of the post-acute care of COVID-19 patients. The key points which we need to keep in mind now is that we need absolutely detailed cognitive and behavior evaluation in the acute stage if possible, and then during the follow-up. This follow-up, this cognitive follow-up, should accompany the patient until the return to work, or in bad evolution to the decision not to return to work. If there are cognitive deficits, I would recommend brain imaging whenever possible. The questions which we already mentioned is the presence of a stroke, which could have passed silent during the acute stage, or it could be a atrophy, either pre-existing or newly occurring brain atrophy. For patients who have specific stroke syndromes, we have obviously the adapted rehabilitation programs, which we use also outside the COVID situation. But we need to design new programs or adapt our programs to the new situation. They need to address deficits in attention, executive dysfunction, and memory disorders. They need to be put into the context of patients who present also motor deficits and who present a very pronounced tiredness, fatigue. All this points out to the very important interdisciplinary rehabilitation endeavor with programs to address this particular aspect of fatigue. The key issues which impact COVID-19 rehabilitation are the following one. In the acute stage, the question is whether a given patient is in acute confusional state or whether the cognitive impairment which he presents when weaned from mechanical ventilation will be lasting. This requires repeated cognitive evaluation during the acute stage and afterwards. We need to address the question of prior cognitive impairment. It may be that patients who presented such cognitive impairment before COVID-19 may be more vulnerable to cognitive deficits, to lasting cognitive deficits afterwards. When we evaluate patients for cognitive deficits in the post-acute stage, we have to do it in the inpatient rehabilitation programs, but when those are finished, we need to continue for these same patients in our outpatient settings. Why such stress on cognitive evaluation and rehabilitation? The cognitive impairment impacts rehabilitation of other aspects of COVID-19 deficits. It does so more than in other clinical situations, and hence this collaboration. Thank you very much for your attention.
Okay. Thank you very much, Professor Clark. To the audience, I apologize for the technical problems. Thank you for solving those, Victoria. we're running late on time. It's already 9 minutes past the hour. Do we have time for just a couple questions? And I have time for a panel discussion. We also need to give information on CME. So Victoria, can you take maybe just 2 questions?
Yeah, let's go ahead and jump in with what are the protocols for testing taste and smell? What are the instruments and items used? And what about assessment?
One of the cognitive evaluation protocols, which have been already mentioned by Barbara Wilson, is the MOCA. It's really easy to administer, as I've mentioned. It's possible to do so even in the acute stage, even if you need to keep some sort of distance. Then it is possible to have other instruments depending on the languages in which you evaluate. Basically, what you need at the beginning is a widespread tools which cover different cognitive functions.
All right, perfect. And let's see. I want to make sure we get one. We have a lot of general COVID ones, but I'm looking for one that might be a little more particular to your talk. Someone asked, I know all the preventative methods count, but what should a physical therapist insist on all of the methods in the course of treating the patients?
Was it about preventive measures?
Preventive measures, yeah.
Okay. Well, I can't comment much on the physiotherapy, but for the cognitive aspects, what we have installed are as much as possible when we are facing the patient for an hour or so, we have plexiglass screens in our offices so that we see the patient, we can even remove our masks and then we disinfect everything. Now in physiotherapy, it's much more difficult, and our colleagues from physiotherapy are much more exposed and need specific masks over other protective measures. But basically, in our place, we use the same protective measures that we use in our other infection situations, you know, like patients with multiple resistant germs and things like that.
All right. I think
that's probably all the time we have for questions. And I don't think we really have time for a panel discussion really today. So I apologize for that. I would like to show the slides on continuing medical education. If you could pull that up, Victoria.
Yeah, absolutely.
I know a number of people had an interest in that. Doing that again, I want to remind you about the 11th World Congress in October. We hope that many of you register for that through the World Federation for Neuro Rehab website. And again, we are planning to have another webinar, at least one, coming up some point. Here's the information on the continuing medical education and how to claim your credit. It's been approved for 2 European CME credits. And you can claim your CME credits through this website with Tracy Mole at wfnr.cu.uk. And I'm sure Tracy will help you with that. Anything anybody else wants to add from the panel? Dr. Feng or anybody else, or Victoria, anything you want to add?
Victoria, can you let me share? So I want to share the website. They're going to watch the video clip.
Yep, absolutely. Go ahead.
Yep.
So Dr. Feng's just filling up where you can watch the recording of this webinar. If you had to tune in late and you missed one of the first lectures, you'd like to go back and watch, this is where it'll be posted. We do need to process the video, so do allow us until Monday afternoon to get it live and up there. Monday afternoon Eastern time in the United States.
And,
Go ahead, Wayne, sorry.
Oh, sorry. So I think it's also important today. We also actually have a YouTube online. I believe there are about 70 attendees actually attended YouTube today. So, so thank you.
Yeah, we filled up our webinar, so we had to start sending people to YouTube Live.
So thank you for all all the panelists. Thank you to Victoria And thank you very much for all the attendees for joining us today. And we hope to have you involved with our next webinar whenever we post that.
Yeah.
So thanks again, everybody.
Hey, David and the panel, can we just regroup for 5 minutes?
Yep, that's fine.
I'll send out a new Zoom link for all of us so we can
A new
end.
link?
Yeah, a new link. Yeah.
All right. Thank you, everybody.
Bye-bye.
Bye, Victoria. Thank you.
We'll see you in a few minutes.